For the second talk, I would like to call the Dr. Prasad Katulanda. He is currently a professor of medicine in University of Columbia. And please, sir, come on the stage for your talk. And that is on the update and evolution of the hypercalcemia.
Good afternoon. First of all, let me thank the Pakistan Endocrine Society and Safis for inviting me to this lovely city of Lahore to talk to you on the evaluation of hypercalcemia. I have no conflicts of interest, and this is my outline. So, hypercalcemia is not a very uncommon reason why we see patients in our hospitals. According to US data, the commonest cause of hyperparathyroidism, primary hyperparathyroidism, about 233 women per 100,000 and about 85 men per 100,000 get hypercalcemia due to hyperparathyroidism. So, overall hypercalcemia might be much higher. We know that untreated hypercalcemia, severe hypercalcemia can be fatal. So, we need proper evaluation of these patients to identify the severity as well as the etiology which will guide us proper management. In addition, primary hyperparathyroidism is a long-standing disease which can cause significant mortality and morbidity. Let me take you through some clinical cases. The first case, I would like particularly the young trainees to shout and say what do you think, so that you can check out at the end whether you have performed correct. So this is a 65-year-old woman, postmenopausal, and had a Colles fracture and found to have high calcium. Any guesses for the probable most likely cause? Shout. Sorry? Right. So second one, 35-year-old woman, young woman, raised calcium on health history, otherwise perfectly healthy. Also in the history, mother also had hypercalcium, but not had stones, fractures or surgeries. Any guesses? Sorry? FHH, excellent. We'll see whether you are correct. So, older man, weight loss, polyuria, raised calcium, high normal phosphate, high ESR, normochromic normocytic anemia. I can see some people shouting multiple myeloma. 45-year-old woman, acutely ill, vomiting, dehydrated, generally unwell, raised calcium, deranged renal functions, had been on thyroxine, calcitriol, calcium, like what we heard in the previous talk for previous papillary carcinoma. Any guesses? Iatrogenic hypercalcemia. The last one, 35-year-old woman diagnosed with insulinoma, when she presented with hypoglycemic seizure. This is one of the women I saw recently. Further investigation revealed raised calcium without symptoms. Great. So, you all know that calcium is very important for our skeletal health. But not only that, calcium is important for membrane excitability, our nervous system, muscle, as well as secretion of a lot of vesicles, including insulin. So, issues in calcium definitely leads to a lot of problems. I think I don't need to go into detail here because my previous speaker elegantly explained this. But any cause which increases the PTH level or activity of PTH, which increases the activity of vitamin D, which increases bone resorption, which reduces the reabsorption of calcium in the kidneys, will lead to hypercalcemia. So this knowledge is important when we investigate patients with raised calcium levels. So we need to have a general understanding of common causes of hypercalcemia. They can be PTH related, like the primary sporadic hyperpara. Then there are inherited variants like the men, familial isolated hyperpara, and then the hyperpara-Jaw syndrome, which is rare, but sometimes we see as endocrinologists. Then the FHH, familial hypocalciuric hypercalcemia, and then tertiary hyperpara we see sometimes with CKD. Then non-parathyroid mediated malignancy is one of the commonest causes. It can be PTH related peptide related or mediated, can be due to osteolytic lesions. Both the malignancies, solid organ malignancies and granulomatous diseases, including the lymphomas, can cause external activation of 1-alpha hydroxylase, leading to increased calcitriol, and then definitely vitamin D intoxication. A lot of medications, particularly thiazides, and then other medications by different actions can cause hypercalcemia. We know a lot of endocrine diseases like hyperthyroidism, acro, FEO, adrenal failure can cause hypercalcemia, and then milk alkali syndrome. We don't see much now when people were taking a lot of alkali and calcium for peptic ulcer disease, but sometimes you can see this in renal failure patients, then immobilization, parenteral nutrition. These are the other causes of hypercalcemia. So we need to first establish that you have true hypercalcemia, because subsequent investigations can be quite expensive and invasive. So if there's doubt, particularly in patients with marginal levels of calcium, and if you suspect them to have hypoalbuminemia or dehydration due to any reason, or prolonged venipuncture procedure with tourniquet can have inappropriately normal calcium levels. So you need to do either albumin corrected calcium assay, or get a lab who does ionized calcium well to do your ionized calcium levels. So it is very important to do this and get this correct, because the calcium levels itself can give clues, because usually the hyperparathyroidism does not cause very high levels of calcium. Then other basic tests like your full blood count, renal functions, alkaline phosphatase, and the ESR, these are also very helpful, and they might shed light to the etiology, so that you don't need to do very extensive and expensive investigations. So good history, physical examination would never replace, is very important and cannot be replaced by investigations. So very important to take drug history, as we suggested in one of the cases. Even the OTC drugs, herbal preparations, family history, very, very important, particularly of hypercalcemia, stones, any other endocrine syndromes. And just look at the patient, any abnormalities in the jaw, history or examination features of CKD, and also very good system inquiry to look for TB, lymphoma, sarcoidosis, and features of endocrine disease, and also are very, very important. If you have any suspicion that the etiology may be due to any drug, it's better you stop it and then re-evaluate the patient rather than proceeding further. Then, as I said, hemoglobin levels would give clues to multiple myeloma, CKD. Phosphate, very useful, because the phosphate is commonly low in causes related to elevated parathyroid action and high in conditions like CKD. ESR will also be very helpful, and alkaline phosphatase suggests bone secondaries. Intact PTH is the cornerstone in further evaluation of hyperparathyroidism, but getting intact PTH, if that is easily possible in other causes of hyperparathyroidism, like in the malignancies, can be useful sometimes, because there's a higher chance of coexisting hyperparathyroidism. So once the hyperparathyroidism is confirmed, you need to see whether the severity of hypercalcemia, because if it is very severe, like the more than 14 milligrams per deciliter total, or more than 3.5 millimoles per liter ionized, you need to promptly institute management options to save life, otherwise the patient might die. Then, if the etiology is not very certain, you need to re-evaluate with calcium and concomitant PTH after you stabilize the patient. So, as I said, the intact PTH is very important for subsequent evaluation. If it is elevated, then you need to look at the phosphate, very useful. If the phosphate is low, it is usually PTH mediated, and then we can also further confirm by getting a urine calcium excretion test, which will be increased. If the phosphate is elevated, this is highly likely that we are dealing with tertiary hyperpara due to CKDE very commonly, and then renal function will give us the answer. If the PTH is in between, it may be still hyperpara, or it can be FHH. So the phosphate can be usually normal in most cases of FHH, but if there is doubt, and also to confirm, we need to do urine calcium excretion, which is very low in FHH. And when the PTH is low, then it is most likely that we are not dealing with PTH related cause, and it may be a non-PTH related cause. And then if there is no overt features of malignancy, then we need to generally do any of these tests, and depending on the cost and availability, we might, and also based on the other investigation findings, we might have to take a stepwise manner, because these are very costly tests, particularly PTH related peptide, vitamin D metabolites, both 125 dihydroxy vitamin D, 25 hydroxy vitamin D, alkphos, and myeloma screening is not that greatly expensive. So based on these, we may be able to diagnose myeloma, then bone mets, and raised PTH-RP is seen in particularly solid organ cancers. Vitamin D metabolites can be helpful in granulomatous disease and also conditions like sarcoidosis, and vitamin D in vitamin D intoxication, vitamin D levels will be high. If you have not already come into a diagnosis of the other conditions by your history and evaluation, you might have to rethink and reinvestigate for other rarer causes of hypercalcemia. So this picture shows the importance of the PTH assay, because here the primary hyperpara, elegantly there is raised PTH in the presence of hypercalcemia. In the non-PTH related causes like malignancy, it is the opposite. Urinary calcium excretion is very useful, particularly to distinguish between primary hyperpara and FHH, and also for clinical decision making in primary hyperpara whether to operate or not. You can either do the 24-hour urine calcium excretion or the fractional excretion of calcium, which is also called calcium creatinine clearance ratio. This is the standard formula which you can find in any textbook or in other literature. And in the FHH, the ratio is less than 0.01, and in primary hyperpara, it is more than 0.02, and there can be sometimes difficult situations in between, which the other features would help us to determine. Imaging can be useful, particularly when we are hunting behind a cancer, granulomatous disease, particularly the chest imaging as well as bone imaging, when we look for secondaries and for myeloma changes. So the first clinical case, I think a fair amount of you got it, and this is the common postmenopausal women who have high risk of primary hyperpara. So she had typical other features of hyperpara, low phosphate, intact PTH raise, and the systemic scan showed an adenoma which was successfully operated. And we, in the medical school, we were told that the classic features of hyperpara, the painful bones, stones, groans, sitting on the throne, and psychic moans. But we don't see very classically these patients, because most of our patients with hypercalcemia are diagnosed early, but these are the classic features that were described in the literature in the past. The second case, again, I think a fair amount of you guessed it, a classic case of familial hypocalciuric hypercalcemia, which was diagnosed with the fractional excretion of calcium, PTH marginally elevated. The third case, again, particularly most of you guessed that, again a case of multiple myeloma, which was diagnosed with the subsequent evaluation for myeloma, PTH suppressed in these cases, but you might not need always unless it's freely available. The fourth case, again, where we need to be very careful. Actually, I have seen several cases of iatrogenic hypercalcemia coming in this picture unless they are careful. So you need to advise them regular follow-ups, and if they are sick and they need to check their calcium levels, and then you need to readjust their replacements. The last case, again, classic case where patient presented with hypoglycemia, diagnosed insulinoma, patient had parathyroid adenoma, and then patient had microprolactinoma, and the main one was diagnosed. So, ladies and gentlemen, when we diagnose biochemically the hyperparathyroidism, we need further evaluation of the patient because we need to determine whether the patient needs surgery, and for that we need proper localization of the culprit lesion or lesions, because it can be unilateral single, it can be multiple, it can be hyperplasia of the glands, or it can be ectopic. We sometimes see ectopic, particularly in the mediastinum, and it can be also syndromic. There are three main clinical phenotypes of hyperpara. It can be symptomatic with renal, skeletal, and neuropsychiatric symptoms. It can be asymptomatic initially, but when you screen, there can be target organ damage involvement, or there may be without target organ involvement. There's a new entity called normocalcemic hyperpara, where despite repeated investigations, you don't find a secondary cause for hyperparathyroidism. They have normal calcium, vitamin D is normal, and they still go on to have hyperparathyroidism. So in hyperparathyroidism, you have several dilemmas, particularly the imaging can be negative. There can be, as I said, multi-gland or even four-gland hyperplasia. You can have ectopic parathyroid. Then you can have persistent disease despite surgery, and then it can be part of familial or syndromic hyperpara, and very rarely hyperparathyroidism can be due to parathyroid malignancy. So there are clear indications for surgery. All patients with symptomatic disease, if they can undergo surgery, should be operated. Asymptomatic disease, there are clear guidelines now available. Younger people, less than 50, quite overtly elevated calcium, more than 1 milligram per deciliter, upper limit of normal, and then the definite skeletal involvement suggested by low BMD, fracture, or renal involvement suggested by EGFR, nephrocalcinosis, nephrolithiasis, or persistent severe hypercalciuria are indications for surgery even in asymptomatic. So surgery should be ideally performed by experienced parathyroid surgeon. There is no evidence for surgery for improving cardiovascular disease or cognitive impairment. Generally selective or minimally invasive approach is recommended because it is associated with short operation time, less scarring, less risk for surrounding structures, less cost, and reduced hospital stay. So to isolate and locate the glands before surgery, pre-operative imaging is recommended, but definitely not to diagnose hyperpara, which should be done by the endocrinologist by biochemical investigation. So there are several modalities available: high-resolution neck ultrasound, technetium 99, sestamibi subtraction scintigraphy with or without SPECT. These two is generally used in most of the centers, including us in Sri Lanka, for diagnosis. And then contrast centers 4D CT is becoming popular, particularly helpful for surgeons. And also there are several novel imaging modalities like the Colin PET and so on are coming up. So there are advantages and disadvantages of all these, but as I said, good ultrasonography by an experienced person coupled with technetium 99 sestamibi with SPECT might be useful to detect most of your cases initially. So irrespective of surgery, sometimes our patients have persistent disease, and intraoperative PTH monitoring has been shown to reduce the risk of persistent disease, because during the surgery, if the patient does not get the reduction of the PTH level, then the surgeon can decide the bilateral exploration. The parathyroid venous sampling is another thing that is generally can be done, particularly since it is very invasive, can be associated with complications. It should be done and reserved for patients who have persistent disease where the imaging is inclusive or discordant. So the genetic screening, sometimes this can be associated with the jaw tumor syndrome, where early bilateral surgery is indicated, and also in Men's syndrome, you should do bilateral dissection, and in FHH you should not operate. So a genetic diagnosis can be sometimes helpful because of these, although these can be diagnosis can be made clinically. So patients with young onset primary hyperpara, multi-gland disease, and family history of hypercalcemia or syndromes, and in patients with atypical or carcinoma should have the genetic testing if it is available. So ladies and gentlemen, if we correctly employ our clinical acumen with a good history examination using standard calcium assay, preferably if needed with ionized calcium or albumin corrected calcium, along with basic tests, we may be able to narrow down our diagnosis in hypercalcemia. Then with the use of PTH, and if needed, more expensive higher tests like PTH related peptide and calcium vitamin D metabolites, we are able to narrow down our diagnosis in most of the cases where we will be able to recommend correct treatment and both reduce mortality and morbidity. Thank you very much.
Thank you so much, sir. Very informative talk. So before proceeding to the question and answer, I would like to take the chair comments. The first chair comment, I would like to call Dr. Neil Sumasundaram. Please, sir, your comments.
Let me thank both speakers for having delivered a wonderful talk. They both highlighted that in hypo and hyper, what is important is common sense, good sound clinical diagnostic skills, proper history, proper examination, use of the biochemistry as we see it, and then most of the problems can be diagnosed like that. They also thank them for highlighting special scenarios like pregnancy, and in Prasad's case where hypercalcemia is present and we have diagnostic dilemmas. So it just comes down to common sense, good sound endocrinological practices which will take us through, I think.
Thank you so much, sir. Sir, for second comment, I would like to call this Amina Mozam from Pakistan.
It's Amna Mozam. So, excellent talks by both of the speakers, and they've highlighted the extremes of the two extremes of calcium metabolism. And yes, they've dived into the depths of the pathophysiology regarding the cause, the options of treatment, and the complications. And just like Sir said, that the core of treatment and diagnosis is the good history and examination. So as long as we do that, I think we'll be successful. Thank you.
Thank you. Dr. Afisa Naz, please, your comment.
Thank you very much. Excellent talk, Dr. Univa, on the hypoparathyroid management in pregnancy. Very important is to recognize that hypoparathyroidism, that pregnancy can itself causes the calcium shifts, which is physiological totally, but it's challenging to manage hypopara in pregnancy. So if you don't know the physiology, you would be misdiagnosing or mistreating. And it's very important to, look after the fetal-maternal complications while you treat the calcium. So excellent. The second talk by Dr. Prasad, one of the, panics, I think you would all agree with me, we have in endocrine calls is, I would rate it as second is hypercalcemia. The calcium zyada aa gaya. So this is where we get calls from. So very precisely, he tabulated all the causes of hypercalcemia. So my 2 cents would be, look for the unmasked hypercalcemia in case of vitamin D deficiency, which is quite common in our part of the world, as Dr. Umar has previously discussed in the osteoporosis panel discussion as well. And plus, you have to, for the long-term follow-up, you have to look after the bone in the long-term follow-up of hypercalcemia as well, as it's a very common cause of, osteoporosis in the long term. So, thank you very much.
Thank you so much. Due to the shortage of time, we will take one question from the audience.
Thank you very much. I think they were both presenters. They did the excellent presentation and very informative. My comment with my Sri Lankan colleague, although it was not mentioned in the presentation, sometime a pregnant lady can come with the hypercalcemia in the first trimester, and we diagnose with workup that she has got, and it was not diagnosed before, and she may be having a primary hyperparathyroid. So what to do in this type of case, because this is a tricky thing, and it needs proper management, in those cases.
Yeah, actually, it would be can be a real challenge because some of the investigations are contraindicated for like the isotope scans and even invasive imaging. So you need to try to, as much as possible, like you can do your hormone assays and so on and come into diagnosis. And if possible, you should try to manage them with the diet, and then also with hydration, and if so, you try to go on till the second trimester, and where sometimes if it is needed, you can perhaps if it is hyperparathyroidism, you can operate them in the second trimester.
Thank you so much, sir. We are running to short of time. So for this, we are concluding this section of section 9 on the calcium and bone metabolism. Thank you so much.